Good morning, good afternoon, and good evening to all the urology trainees, depending upon the place from which you are logging into our YouTube channel to discuss various topics for urology exam preparation. Today, we are going to do episode 68 of our series. We are going to conduct a mock exam on female urology scenarios. We got trainees. Thank you for joining us. Welcome.
Thank you so much for that.
Good. For the first trainee, the time starts now. You are running a dedicated female urology clinic, and one of your colleague has referred you to a patient. She is 28-year-old, and her main problem is pain while maturation. And since it needs a specialist input, the patient is referred to you. How are you going to evaluate?
So I'll see her in the dedicated female urology clinic. I'll take a focus history mainly to see regarding her pain. I'll see what are the aggravating factors and relieving factors, whether it is relieved with the bladder emptying, whether she has already tried any medications and whether that has improved her symptoms, any associated voiding or storage symptoms, any incontinence, any red flag signs like hematuria, UTI, medical history, any medications she is currently on, previous surgical history, any pelvic surgery or radiotherapy, any urethral instrumentation, regarding obstetrics and gynecology history, any history of prolonged labor, and her social history mainly to see her fluid intake, whether she is a smoker, and also the amount of caffeine intake and other caffeinated drinks. I will move on to examination in the presence of a chaperone, general examination to see her performance status, BMI, and a focused clinical examination. Um, Abdominal examination to feel for any palpable bladder, any other palpable lump, external genitalia examination with consent and in the presence of chaperone to see for any abnormal masses, any area of tenderness, and any bleeding coming per vaginum. And I'll also do a sim speculum examination in the supine and lateral position, and also do multiple cough stress test if she is complaining of any incontinence. I will conclude my examination with a neurological examination, and then will go through the investigations available.
Is there any scoring system available? What is your working diagnosis for her?
So if it is if her complaints are mainly pain, then I have to think about the bladder pain syndrome. So the bladder pain syndrome the definition is mainly by the ESSIC definition that we follow. It is a European Society for the Study of Interstitial Cystitis, which defines pain or discomfort associated with the bladder filling, which can be associated with other urinary symptoms like frequency, urgency, nocturia, or voiding symptoms, which has got negative consequences on cognitive, behavioral, and social interactions. And the duration of symptoms as per ESSIC is 6 months. And a symptom score, all ERE symptoms score, is mentioned for the evaluation of bladder pain syndrome. These are mainly two domains that we look for: the interstitial cystitis symptom index and interstitial cystitis problem index. The symptom index has got a total score of 19, and the problem index has got a total score of 16. So these are the initial symptom score. I'll also do her urinalysis, and if there is anything abnormal, urine cultures. By definition, bladder pain syndrome in interstitial cystitis is a diagnosis of exclusion.
Do you know what questions asked in interstitial cystitis symptom index?
Yeah, it's mainly regarding the pain and also associated symptoms like frequency, urgency, and nocturia. And the two symptoms are mainly regarding the how much it is affecting the quality of life and the impact on quality of life.
What about problem index?
Uh, Almost the same questions, but it's mainly regarding how much it is affecting how much problematic it is affecting her. Uh, Sorry, I'm not completely sure about it. I don't know about it. Sorry.
Okay. And let us assume that this patient's interstitial cystitis symptom index comes around 16 out of
Mhm.
20. and problem index comes around 12 out of 16. What does it show?
It shows, I mean, as a straightforward, it shows that she has got severe symptoms in both domains. However, it's mainly used to, once the treatment starts, we can use it to review the symptoms and see if that improves her symptom score. So rather than as a diagnostic tool, it is mainly used to see and validate her symptom improvement with treatment.
Okay. As I said, she's otherwise comfortable. She's married, sexually active, no problem with sexual activity. She has one son born by normal vaginal delivery 3 years back, no prior surgical illness, no other medical illness, and very symptomatic due to the pain. Examination wise, no issues, and focused neurological examination normal. How are you going to take it forward?
So, if clinically this is a bladder pain syndrome, then I will advise her lifestyle changes and behavioral changes. It starts with if she's overweight, decreasing her weight, giving up smoking, giving up caffeinated drinks. There are some trigger factors identified like dietary triggers, so she can keep a food diary and see if there is any triggering factors, she can remove those triggering factors. Moving on, the medical treatment is mainly the neuropathic treatments like amitriptyline. Then other options are gabapentin, pregabalin. Uh, Cimetidine is also described, and also oral pentosan polysulfate, also called Elmiron, 100 milligram TDS. These are the various options that we can try. First of all, I have to inform her that this is a condition where it is difficult to treat, but her symptoms can be controlled. So we have to inform and meet the patient expectations regarding this problem. And also, this is a multidisciplinary, multimodality approach. So I will inform the pain team at the initial phase itself. And after the conservative treatment, if her symptoms are not improving, I will plan for a cystoscopy. And so that will be a GA cystoscopy, mainly to see the capacity of the bladder and also to look for any pathognomonic signs of interstitial cystitis.
So, what signs you're looking for in IC?
So in IC, the main thing that we do, we look for in cystoscopy is for glomerations and for any Hannes also. So there's a classification also, that's also a SIC classification, European Society for Studying Interstitial Cystitis classification, and it is given as 1, 2, 3, 4 cystoscopic findings like normal or glomerulations or Hannes ulcer, and then A, B, C for the histological findings where it is normal or inconclusive or definite inflammatory infiltrates and mast cell presence. So based on that, 1A will be normal, it can go up to 3C, which is a Hannes ulcer. During the cystoscopy, initial cystoscopy is to see if there is any Hannes ulcer, and then hydrodistension with maximum distension of the bladder up to the capacity. So usually we keep the irrigation at the level of 80 centimeter water and keep it for 2 minutes. And after emptying, we'll assess the capacity and refill the bladder. During refilling, if there are petechial hemorrhages in at least 10 of them in at least 3 quadrants, then it is diagnostic of glomerulations. If there is a ulcer-like appearance, which is like a ulceration which is called as Hannes ulcer, then that is pathognomonic of BPSIC.
Is there any role for biopsy in this patient?
Straightforward, the guideline says that for diagnostic purposes there is no role. However, if there is a Hannes ulcer, the recommendation is to take a biopsy and go for a TUR fulguration of the Hannes ulcer area. It has shown that if you fulgurate the Hannes ulcer, there is a good response to the pain for at least 3 years.
Okay, you mentioned about the oral medications. Her cystoscopy did show evidence of glomerulations, but no Hallner's ulcers present. She's not responding well to her oral medications. What other options you have?
The next step of treatment option for her is intravesical installations. The options available are cystistat or ialuril, or even Parsons cocktail is described. Cystistat is sodium hyaluronate, Ialuril is a combination of sodium hyaluronate and chondroitin sulfate, and Parsons cocktail is a local pharmacy made combination of heparin, sodium bicarbonate, and lignocaine.
So how do you manage her in your setting? Which kind of intravesical treatment you will give?
So we usually give Ialuril, and we start it with a weekly dose for 6 weeks. And if our symptoms are improving, then a maintenance dose every 2 weeks is given, which is tapered over to every month for at least 6 months, and see if our symptoms are remaining stable.
Okay, good. We'll stop there. Good presentation, very straightforward scenario. There is no way you can make any mistakes. I think you stumbled a little bit on the IC symptom index. From the references which I searched and got, so I see symptom index as score from 0 to 20, and there are only
Okay.
4 questions, and the questions are very straightforward. For example, the first question is how strong you need to urinate without any warning, and second one is
Okay.
something like how you need to urinate less than 2 hours after you finished your urinating. That's almost like doing a frequency. The third one is typically getting up in the night, so nocturnal frequency. The fourth one
Yeah.
is a pain or burning sensation in the bladder. So you can uh, just remember it with single words rather than a full question. So single words are urgency, frequency, nocturia, pain. That's it.
Okay. Yeah.
And every question has 5 options. All the 5 options were almost similar. Not at all means 0, less than 1 time in 5, half of the time, about half the time, more than half of the time, almost always in the score of 1, 2, 3, 4, 5. So that you can easily remember. So IC symptom index is sorted 0 to 20. IC problem index, as you said, almost similar 4 questions. The first question will be of frequency, second question will be nocturia, third question will be like urgency, the fourth question will be pain. The only difference is instead of 5 options, here we will have only the score up to 4. So it will be like no problem 0, very small problem, medium problem, big problem.
Okay.
So it's sometimes it's very easy to reproduce if you think in this order. So 4 words for symptom index, 4 words for problem index, and the score is 0 to 20 and 0 to 16. And the symptom index is based upon how many times it happens, and problem index based upon very small, medium, big. Just remember words rather than the full sentences. That makes the job more easy. And as you said, it's more for prognostic. Sometimes people tend to overscore, just like IPSS score, thinking that they will give them better attention. And sometimes patients' actual problem may be of quite low volume, but everything is because of how she is perceiving it. But if she responds well, it's very nice to see that the scores are improving. And as I said to you once in the IPSS score, you can little bit twitch her scores in the follow up to give a kind of a mental boost to see that she is improving. This is a kind of a practical point. And there are other things known as like physiological components which we have a mnemonic like U point, urological, psychological. So like that you can use the U point to remember the various branches in which this interstitial cystitis or bladder pain syndrome can present. Very straightforward scenario. The only thing you may not be seeing very frequently in your practice, but good, well done. Okay,
Thank you. Thanks.
we'll go for the next scenario. Okay,
Mhm. Yeah.
good. The next scenario is you got a male patient in the clinic who is 44-year-old presented with significant pain and slowness in passing urine. How are you going to evaluate?
I would see him in my urology clinic with the pre-filled IPSS score, flow rate on arrival, and post-viral residual with urine dipstick. I take focus history, examine him, arrange appropriate investigation in the history. I would like to know how long he's been having this problem, whether he had any previous urological diagnosis, any previous urological procedures, is known to have any urological instrumentation in the past. and any history of sexually transmitted infections, and any urethral discharges, any red flag symptoms such as hematuria, recurrent urinary tract infections, and abdominal pain, his past medical history, especially diabetes, any other neurological illnesses, whether he has constipation, and any his other surgical history, and the social history, including smoking history. In the examination, with the presence of chaperone, with his consent, I would examine his general condition, his BMI status, abdomen for any tenderness, loin tenderness, palpable bladder, genital examination, especially to see his foreskin, any tightness, any urethral narrowing, and the testicle examination, and the DRE to feel this, the prostate and the anal tone. And I would complete with a focused neurological examination. After that, I would go through his IPSS score and discuss with him the bothersome symptoms, and go through the uroflow and the post-viral residual and urine dipstick, and I would go through the other blood reports done by the GP, such as full blood count, use and ease.
Okay, very youngish patient presenting with weak stream and slowness in passing urine. In the external genitalia examination, anything specific you will concentrate on?
One thing is foreskin, whether he has any foreskin and the glands, whether to see whether he has any evidence of balanitis erotica obliterans and urethral meatus. That is my worry.
Okay, and as you said, he's comfortable otherwise, he's healthy, no past history of any medical illness. Examination showed very flat prostate, maybe measuring 20 cc. IPSS score shows very high values, like he's scoring at 26 out of 35 and QOL 6 out of 6. He is married with one boy, otherwise no significant sexual problems. How are you going to evaluate him further? Blood tests were normal.
I would like to know the tracing of the flow rate to see in the if he has any box type pattern, which is suggestive of urethral stricture disease. Do we have that information, please? And
Yes.
I also, one thing I forgot to mention in the history, I would ask whether he had any previous trauma to the perineal region as well.
Okay, he had no previous trauma, and as you said, his uroflowmetry showed a flat curve suggestive of urethral stricture, box type with Qmax of 6 ml per second. He emptied the bladder completely. His water volume is 180 ml.
So in this case, with this Qmax and the type of pattern, I would suspect a urethral stricture. So I further investigate him with the urethrogram, ascending urethrogram, based on the latest EA guideline, that is a first line investigation suggested. And the other option I have is to do a flexible cystoscopy.
Okay, you can see the picture now.
Yes. So this is the X-ray pictures of ascending cystourethrogram. The most striking abnormality is a narrowing in the bulbar urethra level. The anterior urethra looks normal, and the prostatic urethra also look normal, and I couldn't see whether contrast is entering the bladder. I would like to see the other pictures, and also would like to discuss this with the radiologist who has performed the procedure.
Okay, why there is a kind of a bend here?
I believe that is the position of the patient.
Okay.
And also maybe due to the stricture, that someone is trying to push the contrast hard, and it's not entering, passing the stricture.
Okay, so now you know the stricture. So what are you going to do now?
So it's a bulbar stricture. I believe it's approximately 1 to 2 centimeter. So I would counsel him about the option of management. I would tell him that the problem he has is due to the narrowing in the urethra. So I would list him for general anesthetic procedure. It's a cystoscopy and optical ureterotomy for this bulbar stricture to start with.
Okay, so what precautions you will take in optical ureterotomy?
The one thing is the consent. From the consenting, I would tell him that in case of failure to pass the camera or the instrument, sometimes patient might end up in suprapubic catheter insertion. So I would take that in the consent. At the time of the procedure, I would make sure that patient gets preoperative antibiotics, and I do a cystoscopy first to delineate the anatomy of the urethra, and I'll pass a guide wire, and then over that I would use the knife optical ureterotome. I'd make sure that the sphincter is not damaged. If it is close to the sphincter, my option is to do a urethral dilatation with hydrophilic S dilators.
Okay, is internal urethrotomy goes fine. How are you going to exit strategy? What is the exit strategy?
So once it's done, I will do the cystoscopy to the bladder to complete, have a bladder inspection as well. After that, I will leave the catheter, a 16-French catheter. I'll pass over the guide wire or through the sheath of this optical ureterotomy. And I would remove the catheter in 3 days, and I would refer him to my nurse specialist to teach him self-intermittent catheterization. I would see him in the clinic in 3 months with a repeat IPSS score and flow rate to see whether it has helped him.
Okay, in 3 months' time, he seems to be nicely settled. His IPSS score shows good improvement. Hence, you discharge him back to the GP, and he presents after 1.5 years with similar symptoms.
So I would re-evaluate him with a history examination and investigate him again with a repeat repeat retrograde ureterogram to see whether the stricture has recurred. So my further, and at this time, I would also see whether the symptoms are not due to the enlarged prostate as well. So it's based on the retrograde ureterogram findings. I would advise him the further management.
The retrograde ureterogram shows almost similar picture with maybe 5 millimeter more stricture than the present picture what you're seeing.
So in the case of recurrent stricture, the repeat visual VIU is an option, but it's not the best option because these strictures tend to recur again and again. So the best option of management for him is to do a urethroplasty. So I would see whether if it is done in my center, I would counsel him for that. Otherwise, I would refer him to a tertiary center where the urethroplasty is being carried out.
Okay, so what is the principle for urethroplasty?
It will be done as an open surgery under general anesthetic. It's a perineal insertion. The urethra is entered, the stricture is divided, and if the stricture is less than 2 centimeter, primary anastomosis is carried out. If it is more than 2 centimeter, a substitution urethroplasty with a buccal mucosal graft will be necessary. It will be a staged procedure sometimes.
So what are all the places you can take the graft?
It's a buccal mucosal graft. It's a preferred one and the commonly used one. And I'm aware that a pre-auricular graft also can be done.
Okay, so you're doing a buccal mucosal graft, and is there any techniques you are aware of? What are all the different ways by which we can do the buccal mucosal graft urethroplasty?
Sorry, the names are not coming to my mind at the moment. Sorry.
Okay, so how are you going to follow him up?
Then again, he will have a catheter for a couple of weeks. On discharge, I would advise him to avoid sexual intercourse for at least 6 weeks and avoid the erection of the penis. And after 2 weeks, a pericatheter ureterogram is done and the catheter will be removed. And the patient will be seen in 3 months with the further IPSS and flow rate as a review.
So how will you do the pericatheter ureterogram?
So we'll keep the catheter as it is, pass a feeding tube next to the catheter, and the contrast is injected while screening with a fluoroscopy to see whether there's any leak around the anastomotic size. And if it is not there, the catheter will be removed at the same time.
Okay, he has no leak in the pericatheter ureterogram. You are removing the catheter. How are you going to follow him up?
I see him in the clinic in 3 months with the repeat IPSS and flow rate to see the improvement.
Okay, his IPSS score shows good improvement, say around 11 out of 35. QOL is quite happy. Okay, we'll stop there. Good, that's a nice presentation. Only few things I need to add. One is if the patient is very young and if you know that this is a possible urethral stricture, it's a very funny, I don't know, historically the male urethral strictures are mostly asked in the female urology table. It is not used in, not asked in the BPH table or male LUTS table. So just be careful in that. So once you get a male patient, the few possibilities in the female and functional urology table is urethral stricture, and need for male sling post prostatectomy and male stress urinary incontinence, it can go in these ways. I think you guys know that already. Okay. Yeah. So in examination, you can include the urethral examination also. You shared about the perpusal examination and glands. You can palpate the urethra to look for any fibrosis and any scars. And sometimes the BXO, if it extends there, you can palpate it. And the bend here is because during the ascending urethrogram, the radiologist or whoever performing is not stretching the penis. If the penis is appropriately stretched, this bend will not happen. So this is a physiological normal bend. You can see the urethral lumen is very, very adequate. And the stricture starts here. As you said, it may be like 2 centimeter stricture with multiple small narrow areas and little bit wider areas in between. And this is the area of the sphincter will come. Patient is relaxed, that's why there is no sphincter relaxation you can see. And then the bulbar urethra, the sphincter will come here. The pictures should be taken much more proximal. And the bulbar cone is nicely preserved. So it's more of a distal bulbar urethral stricture, and this is suitable for end-to-end urethroplasty, or it is also called as anastomotic urethroplasty or buccal mucosal graft, which slightly has a better value. But if it is too much proximal, usually anastomotic urethroplasty is not useful. You need a buccal mucosal graft. And yeah, otherwise I'm happy with other answers. Good.
Thank you.
Can we go for next one?
Yeah, we can. Thank you.
Good.
Sorry, Mr. Zanshagran.
Yeah.
Is there anyone else waiting for? I can see one more trainee in the.
Anyone wish to take the next scenario? I think they want to listen.
I'm happy to take the next scenario.
You want to listen, okay? Yeah.
No, I know. I'm happy to be on the hot seat.
Okay. All right. Okay. Perfect. So I'll mute myself. Thank you.
Okay. So you are going to present. Your time starts now. You have a 35-year-old lady presents with history of pain while passing urine, and she feels her urine stream is very slow, and the symptoms are present for 6 months. How are you going to evaluate her?
So I will see her in my female urology clinic. She will attend with a 3-day bladder diary as well as a validated ICIQ questionnaire. On arrival, she will have urine dip, flow rate, and residual, after which I will take a focused urologic history to clarify more information about the pain, whether or not it's related to bladder filling or certain food, menstrual period, etc. I also want to know about urinary symptoms, the slow stream, and any other urinary symptoms she may have. In addition, I want to ask about red flags, such as visible hematuria, and then I will clarify about any medications, comorbidities, and performance status. Following this, I will examine her in the presence of a chaperone with consent, general examination, including checking her blood pressure and the body mass index, and abdominal examination to check for palpable bladder. And then I will, with consent, I will examine the perineum to see whether there's any obvious abnormalities noted. And after that, I will carry out a focused neurologic examination.
Okay. Her history is quite uneventful, other than this past 3 to 6 months where she is suffering with this blockage in passing urine. She has no prior significant histories. She has 3 children, all 3 born by cesarean delivery. Her sexual activity is much more hampered now because of the pain, and she has no other bowel symptoms. You examine her in the presence of the chaperone. She is obese. Her BMI is 32. Abdomen and external examination were non-contributory except for a bulge in the next to the urethral meatus. So how are you going to evaluate her further?
So with the bulge around the urethral meatus, I will be concerned probably she's got urethral diverticulum. I will, because of the pain, I will be inclined to organize flexible cystoscopy just to try and look in the urethra and also check the bladder and exclude any bladder stones or any abnormalities in the bladder contributing to the pain. If the cystoscopy is reassuring, I will arrange a pelvic MRI scan to further delineate the swelling.
Flexible cystoscopy is normal. There was some difficulty in passing the scope, but once you enter the bladder looked normal. Bilateral urethral is normal. Per-vaginal examination did showed a bulge around surrounding the urethral meatus. I'm going to share the MRI image. Okay, so this is our MRI image. You're able to see the images now?
Yes.
Okay, I'm just going to slowly scroll through.
So this is an axial MRI scan through the pelvis. It's a T2 weighted image. The most obvious abnormality is a concentric swelling around the urethra with findings suggestive of urethral diverticulum.
Okay, so this is the sagittal view. Okay, it's almost same finding. And she also had a fluoroscopy which did show some extravasation of contrast from the urethra. Okay, so what is your impression?
So my impression is urethral diverticulum, and I will discuss the images in the pelvic MDT and gain a consensus prior to seeing her in clinic.
Okay, so what will be the discussion which may happen in the pelvic MDT?
So I will just to run through the images again with the radiologist and for them to confirm from them that they are happy that this is just a urethral diverticulum with no signs of malignancy.
Okay, so how are you going to treat her further? There is no signs of malignancy, seems to be a simple urethral diverticulum.
So I will see this lady in clinic in the presence of a clinical nurse specialist, and I will discuss options of treatment. I will discuss options of management with her, which will be either masterly inactivity and surveillance, or surgical operation, which will be either marsupialization or excision of the diverticulum.
What do you mean by marsupialization?
So the marsupialization involves laying open and turning the diverticulum over on itself in order to prevent reaccumulation of the fluid.
Okay, so what is your choice, marsupialization or excision?
So I will counsel her. There are pros and cons of either approach. Excision is better because we're able to kill the diverticulum by excising it, but I will warn her about the possible side effects, including vaginal asymmetry and stenosis, because I will need to use a Matthias flat pad, a fat pad for the construction. The advantage of the excision is the success rate is more than 90%, and we can also send it off for histology to definitely exclude malignancy. Marsupialization, on the other hand, she will not likely experience the vaginal stenosis, sexual dysfunction after. The incidence of that is lower, but there will be no histology thereafter, and then the success rate I will put about 75%.
Okay, and what is that Matthias flap? How are you going to take it? What is the blood supply?
So it's a local vaginal flap, which is taken as a fat pad from the labia labia majora, and that is then used to further reinforce the repair to reduce the chances of breakdown.
Okay. Do you know what is the blood supply?
It's from the internal pudendal artery. That's what I think at top of my head, but I will need to double check that.
Okay. So how are you going to follow her up?
So postoperatively, I will review the histology just to be sure it's all benign, and then I will usually I will put a catheter postoperatively, and then I will do a cystogram after about 14 days to ensure the wounds have all healed, and then I will retrieve the histology and see her in clinic in about 6 weeks just to be sure all the wounds have healed and that she's fine and well.
Okay, what will be the long-term follow-up for her?
So long-term, there is, because we have excised it, so I'm no longer worried about malignancy. There is a small risk of vaginal stenosis, but I will just, I will see her again 3 months, and if she's fine, I can give her open access to call my secretary if she develops any problem in future.
Okay, that's good. Well done. Your time is up. Again, it's a very box standard scenario. You did very well. Read a little bit about the Mortius vaginal flap because it can sometimes come in few areas. So it has blood supply both from the superior and the inferior pedicle. And depending upon the individual patient, you need to decide whether you want to use the superior pedicle and sacrifice the inferior pedicle or vice versa. Inferior pudendal artery is the main artery branch from which this happens. The few main things, other things are in the post-operative period, you may have to ask her to restrict from sexual activity for maybe like 4 weeks or 6 weeks because number one, it will be very painful and you don't want any unnecessary pressure over the flap area. And patient will have a catheter at least for maybe 2 days, 3 days so that the swelling and edema, everything will settle down by the time. And you can also warn her about the possible urethral stricture. You said about vaginal stricture, vaginal asymmetry and those things, but you may have to inform about the urethral stricture. Since this is a specialty which is slightly more specialized, there is nothing wrong in involving saying that I will refer her to tertiary center female urologist, but there is nothing wrong you can do, but it's nice to show that you are involving a specialist in this. Okay.
Thank you very much.
Good. We'll go for the fourth scenario.
Yeah, before we start, Mr.
Yeah.
Couple of questions. So in the cystitis, do we have the pelvic empty meeting or no?
Yes, pelvic empty is good for everyone, whether it is interstitial.
So what are the who are the participants in the pelvic empty?
Yeah, it is not like a pelvic MDT. In my practice, it is known as urogynecological MDT. The referral criteria is very simple. You should have a patient who has something complex than normal. Say, for example, interstitial cystitis, you have treated everything, but she's not responding. You're going for something more like costly drugs, Botox, or something like that. And for urethral diverticulum, definitely pelvic MDT because it's better to go through them to make sure there is no malignancy in the diverticulum. And similarly, nowadays, all the tape patients, sling patients, colpo suspension patients, they are all discussed through that. It consists radiologist, gynecologist, urologist, and maybe something like a urogynecologist or the gynecologist with urology interest, and pain team and physiotherapist with interest in pelvic floor exercises.
Thank you.
Okay. Happy for the last scenario for today?
Yeah.
Good. Your time starts now. You have a 22-year-old woman presents with history of urinary frequency both day and night.
Okay. So I see this lady in my functional urology clinic along with the incontinence nurse and along with the bladder diary. And then with the blood diary, BMI and urine dip, and then I will ask about the urgency, frequency, and the LUTs. So I will ask about the history of the LUTs and any whether it is associated with the incontinence or not frequency. and then nocturia, and then I also ask about the red flag symptoms like hematuria and recurrent UTIs in the past. I will also inquire her fluid intake, especially alcohol or caffeinated or fizzy drinks, and then bowel and sexual history. And if there is she has a obstetric history, if she has a children, and any previous treatment for that or any pelvic intervention in the past. Then I will move on to the examination. In the examination, with the consent and with the pelvic, the chaperone, I will feel the abdomen, suprapubic area, and then the perineal examination. And in the perineal examination, I will do in the supine and in the left lateral position. In the spine, I will see any prolapse. And of course, she's a young, so her estrogenization status will be okay, but any other perineal pathology. And in the lateral position, I will see the rectocele and the rectocele and the cystocele with the same speculum. And then I will move on to the investigations, which will be the post-voided with the residual baseline urine baseline renal functions.
Okay, as you said, she is quite young and fit, no medical comorbidities. She has 4 children born by normal vaginal delivery. She is a smoker. Examination showed her BMI is quite high at 35. Other than that, there are no physical abnormalities. Your abdomen and extragenitally examinations were non-contributory. Her bladder diary showed evidence of occasional urine leak, maybe twice in the daytime, and frequency is 11 times in the day on average and 4 times in the night on average. Functional bladder capacity 120 ml. She drinks good amount of coffee and tea and also fizzy drinks. How are you going to treat her further?
So in this case, I will it will be the good in detailed discussions encouraging her change in the lifestyle and then the pelvic floor exercise and bladder retraining. In the changing in the lifestyle, I will encourage her to lose her weight, to cut down smoking and decaf coffee and tea, and then on the pelvic floor muscle exercise, I will advise her to do the supervised pelvic floor muscle exercise. For that, I will refer her to my physiotherapy department. And regarding her bladder retraining, I will advise her to do herself while she's in her office or in the home. And the idea is to delay slowly to increase the interval to pass the urine in between the voiding.
Why she needs to change to decaffeinated drinks? What is the relation?
Because the caffeine and in the coffee is also causes the steam, which has the urgency and frequency, which cause the increase um, overactivity of the bladder.
Okay, so she's following your lifestyle changes and pelvic floor exercise. You are following her up in 2 months' time. She's not very happy. She doesn't feel that there is much improvement happened.
So then I will offer her the according to Parnas guideline antimuscarinic agents, which will be the oxybutynin, and or then if it doesn't, I will review with this one. If it did in 6 weeks time, if it did not work, then I will offer the beta 3 agonist, which will be the mirabegron, and then if I will take it from there.
Why oxybutynin? What is the dose of oxybutynin you will use?
Oxybutynin is a 5 milligram POTDS because it was a nice recommendation, but in my practice, I will go for the solifenacin because it has the better results.
What are all the side effects of solifenacin?
Solifenacin, the side effects are it's called the dry mouth, constipation, and dyspepsia.
Okay, you said you will start mirabegron if these are not working. Why mirabegron is different from the anticholinergics?
Because the mode of action is different. It called it is a M3 receptor agonist, which called the relaxation of the smooth muscles of the detrusor, giving the more capacity of the bladder.
I'm sorry, what agonist is that?
M3 agonist.
M3, okay. And let us assume this patient take these medications but troubled by the side effects. What are all the side effects of mirabegron?
Mirabegron side effects, the mainly is the hypertension, which is the uncontrolled hypertension. Other is the also is called the dry mouth and dyspepsia.
Okay, so she is troubled by the side effects and she's not happy with the medications. What's your next step?
The next step, I will again reevaluate her with the bladder diary, flow rates, and PVR, and then I will organize urodynamic studies on her and take it from there.
Okay, this is her urodynamic tracing. Can you read this for me?
So this is the filling cystometry, and I can see this is a good quality study because there's an interval cuff present there, and I can see that she has some detrusor overactivity during the filling phase, especially when after the bladder volume was 135 to 150 mil, and about the leak, I cannot see any leak there. So it is uh, overactive bladder finding of the.
Okay, how will you differentiate that this is due to overactivity from the detrusor, not the abdominal straining?
So if you see the blood on this one, when the cuff, the intravesical pressure also rise along with the detrusor muscle.
Okay, so how are you going to treat her?
So I will discuss her case in my pelvic urogyne MDT, and then I will offer her intravesical Botox injection, making sure that she is happy to do self-intermittent catheterization, and there is no contraindication for that.
Why she has to do intermittent self-catheterization?
Because there is chances about 40% patients they go temporarily into the retention after the intravesical Botox injection.
Okay, so how are you going to do Botox injections for her?
So Botox injection after suitably prepared patient, the contraindications are ruled out in the theater, the WHO checklist and covert status checklist done. Patient is in the lithotomy position, and I will ask my anesthetist not to give aminoglycoside antibiotic. I will offer comoxiclav, and then I will do the the cystoscopy, and then after the cystoscopy, I will make my 100 milligram of 100 milligram of intravesical of Botox A into 20 mils, and I will inject 1 mil at each, sparing the trigone into the submucosa.
Okay. There are two regimens like 1 ml 20 injections, 2 ml 10 injections. Which one you prefer?
In my practice, I will prefer the more wider area, which is the 1 ml in 20 places.
Okay, why? Okay, we'll stop here. Why you're not giving aminoglycosides?
Because it enhances the action of Botox.
Okay, so there are some evidence to say that the aminoglycoside patients far much less when they are given the Botox injections. Maybe due to some interactions, the Botox efficiency is not good. Okay. In the urodynamics for the question, how you are sure that this is due to a pure detrusor contraction is you are not able to see any abdominal contraction. While if it is due to patient straining like cough, you can see that the abdomen contraction is noted. Possibly in exam, you can show this much more clearer. And the reason why we are changing to the decaffeinated drinks is the caffeinated drinks also serve as diuretics. So apart from the caffeine irritating the bladder, it's also diuretics. And mirabegron is a beta 3 agonist.
Sorry, it's a beta 3. I thought I'm 3 now. Yeah.
Beta 3 agonist, and side effects you should include palpitation also. Apart from increase in blood pressure, patient can feel palpitation, and you can give an advice that it's better for the patient to visit the GP surgery to have the blood pressure checked maybe 3 to 4 days later. Okay.
Yeah.
Good. Injecting 1 ml 20 sites is better because, for example, if any of the injection has gone like wasted in the bladder cavity or wasted in the submucosal layer, if it is like 2 ml 10 injections, if one injection is unfortunately given wrongly, which means like 1 by 10th of the dose is not going to work. So if you give 1 ml in 20 injections, even if one of the injections is not appropriately given, you are losing only 1 by 20th of the injection. So it's nice to give a widespread, sparing the trigone away from the ureteric orifice, 20 injections like in a fan shaped manner, so that you're not injecting the same place. Okay.
Yep.
Good. Well done. The last scenario is a quite box standard scenario. The last scenario may be the most commonest of all the scenarios, but we did the urethral stricture, male urethral stricture, urethral diverticulum, and interstitial cystitis mainly because to complete, because we have done other things many times. And any questions before we conclude? Good, because we have discussed stress urinary incontinence.
Mr. Dhanasekaran, sorry.
Yeah,
Mr. Dhanasekaran.
yeah, go ahead.
Yeah. How important is the posterior urethral fracture defects for FRCS?
Very rare, because nowadays there is a trauma surgery and those things are there. Even if it's very rare, I don't think it was ever asked. Maybe just read the principles so that you'll be able to cover that.
Okay, all right.
Most common trauma, if as long as the patient is not having a big separation, they are suitable for end-to-end urethroplasty, because there is no BXO. You don't really need long buccal mucosal graft. Most of these patients will have SPC to temporarily divert the urine, so you will be having an access from the top and below to create an end-to-end anastomosis once the pelvic fracture, everything is settled down.
All right.
Good.
So much. This was a really helpful session. Thank you.
Yes.
And so helpful. Thank you so much for that.
Yes, I think the last few weeks near the exam, we are doing the rarer scenarios, which is much more helpful than doing the same scenarios which you already exposed in various training programs.
Yeah.
Very good. If there is no further questions, we can conclude now. We will discuss pineal cancer tomorrow morning. Okay?
Thank you.
Thank you very much.
Good. Have a nice rest of the evening. Bye.
Thank you. Bye-bye.